leading on this project, can't be here today, so I'm just sort of covering her, doing a very brief introduction and then passing over to our expert. So Dr. Brian Halliday is here today to cover today's session. So this forms parts of our webinar series on inherited cardiac conditions. Just again, I will give a very brief introduction as a preview. We've got a quick poll then to complete, then there's sort of the main event, and then a brief poll at the end of today's session. So, like I said, just a bit of background about who we are as the Genomic Medicine Service, and why we exist. So I am Marianne. So my name is Marianne, and I am the lead midwife for the South East GMSA. So we form one of the 7 Genomic Medicine Services Alliance around England. The main purpose of the Genomic Medicine Service is to really embed genomics in mainstream nursing and midwifery practice. So to come away from that sort of only specialists have an interest in genomics, but really trying to implement that equity of service and that understanding across the workforce so that we're able to provide the best possible testing, interventions and outcomes for all service users in the NHS. So like I said, our purpose really is to try and embed that knowledge and understanding in all areas of practice throughout nursing and midwifery. So we take this novice to expert approach where that initial engagement with everybody to get that sort of genomic message out there, and then more specialist training like today's session where we've got sort of specialist nurses with a key interest, and then we've got that really sort of formal education where there's genomic masters training that can be accessed as well. And just thinking about today's session and why you're here. So we have a series of webinars which have been looking into inherited cardiac conditions. This is through funding gained via the Burnett Trust for Nursing. So it was really with the aim of creating interventions in inherited cardiac conditions. And our focus has been on sort of extending that knowledge within the nursing workforce, which is why this webinar today is happening. And like I said, this forms part of one of 3 webinars. This is the final one, so if you've missed the other 2, they are recorded and able to access, and today's session will be recorded as well. And just a final little bit from me before I hand over to Brian. We have an ambassador program, so it's really a call to all of you here today that we are really pushing this forward so that we would have an ambassador nurse and midwives in all trusts that cover the South East. So at the moment we've got 35 ambassadors, and that role is really just to sort of bridge that gap to bring genomics into practice, so, to sort of provide knowledge and information on recent genomic projects and learning available. So it's just a real plea to anybody who may want to be an ambassador or who may want to nominate an ambassador from your trust. We would love for all sort of nurses and midwives to be represented within each trust throughout the South East. And here again is just some links to some resources. We're having a specialist session today, but there's a lot of generic sort of resources out there. And there's some links there, and then also links to some of the more formal education. So just that final little bit from me is our big message is that we really would love you to join our ambassador program. We want to standardise genomic learning throughout the NHS and nursing and midwifery. So please do get in touch if you've got any questions or you would like to nominate an ambassador. And there's just a link as well to the South East GMSA. I hopefully now we will just share a quick poll before we start the section with Brian. So let me stop sharing from my side. And hopefully Carmel will be able to share that poll with you, and then we will hand over to Dr. Brian Halliday, who's going to take today's session with you.
So I've just put a link to our poll as well, and I'm also going to bring it up on screen. So if you could, I'll give you a minute to join before we do the pre-session poll. I've given it a minute, so if everyone's happy for me to move on, let me just share the first one. So, how familiar are you with MRIs and ICCs? And you can pick not familiar, somewhat familiar, very familiar. Okay, I think everyone's voted. So the next one. Do you ever look at MRI images and or reports as part of your job? So yes or no? Ooh, okay. I think everyone's already voted. So, and then the last one is how optimistic are you that today's seminar will improve your knowledge of MRIs in ICCs? With thank you so much. Give it a few more seconds. It's amazing. Right. And that's all the questions I have pre-session, and then post-session, I will be back with a poll. Thank you so much. And then I'll hand over to Marianne. Ryan.
Yeah, so just to introduce you, so we've got Dr. Brian Halliday today. He's going to be running the session, and it's over to you.
Super. Okay, so well, hopefully I can improve your knowledge even if you don't think so. Um, so yes, and hopefully we can get more familiar what we mean with phrases that we use in MRI reports and to try to decode any of the mystery that there is. So yeah, so I'm a cardiologist and a researcher in cardiomyopathy and I use a lot of MRI and report in my research and report MRI as part of my clinical job too. So um, let's get started. I mean, lots of you are going to be very familiar with this, and maybe some of you less familiar. But I think terminology that we use to describe cardiomyopathies themselves can be confusing, particularly for people if they don't encounter them every day. And I think one of the confusing things is that they seem to update every 6 months or so, whenever we get a new set of guidelines or a new group of people that decide what we're going to call them. And I think in very simple terms, the way that I look at it is that we have a group of conditions where the primary feature is a weak left-sided a weak left side of the heart, predominantly the left ventricle, and we tend to call them dilated cardiomyopathy, or more recently, if the ventricle is not dilated, non-dilated left ventricular cardiomyopathy. Twitchy hearts, we use the label as ARVC, arrhythmogenic right ventricular cardiomyopathy, but the more we understand them, the more we realize that actually arrhythmogenic cardiomyopathy caused by genetic variants in desmosomal genes, so things like plakophilin and desmoplakin, are actually predominantly biventricular diseases, ones that affect both the left and the right side of the heart. So that's led to the coining of the terms arrhythmogenic cardiomyopathy, which is sometimes abbreviated to AVC or ACM. And if we have left-sided predominant arrhythmogenic cardiomyopathies, particularly with things like desmoplakin and perhaps vitamin C, will use the term ALVC. And then thick hearts, we have hypertrophic cardiomyopathy caused by genetic variants in sarcomeric genes. Sarcomeric genes, the building blocks of our cells, of our heart muscle cells, the things that cause our heart to contract, our little heart cells to contract. And that's perhaps 50% of people we diagnose with hypertrophic cardiomyopathy. We've got a big pool who are gene negative. Okay, those are older people generally with high blood pressure, more and more overweight, type 2 diabetic. and that's probably an interaction between these environmental things and then probably also polygenic susceptibility. So not a single variant in a single gene, but multiple variants that are actually quite common in the general population that act to increase susceptibility just a little bit. But whenever you add the cumulative effect of many of them up together, then you get a phenotype whenever there's interaction with things like high blood pressure in the environment. And then we've got rarer things that causes thick hearts, so cardiac amyloid and then storage and mitochondrial disease. An MRI can be critical in differentiating the 5 different causes of a thick heart that we see there. So we'll start with dilated cardiomyopathy. So dilated cardiomyopathy is not a single disease, but it's probably better viewed as a family of diseases, each with a common phenotype, a mixture of intrinsic and acquired susceptibility, a mixture of monogenic disease caused by single rare genetic variants, and then polygenic susceptibility caused by the cumulative effect of common variants, and then the interaction of this genetic susceptibility with different things that people encounter in the environment, whether that is a woman who becomes pregnant, who's a carrier of a titin truncation, or a 70-year-old who drinks too much alcohol. So there's a mixture of nature and nurture here. So what can dilated cardiomyopathy do in terms of helping us to characterize dilated cardiomyopathy? Well, we get excellent imaging of the heart. So rather than looking in a snowstorm with echocardiography, we can actually see the walls of the heart, and this allows us to quantify the volumes of each chamber. It allows us to calculate the left ventricular ejection fraction with really great precision. But perhaps the greatest benefit in MRI over echocardiogram is its ability to characterize left ventricular tissue. Okay, so on the left-hand image here, we see a short axis view. So we see black muscle, in a donut style appearance here with the left ventricular cavity in the middle. We see some trabeculations here. And here, this is a late gadolinium enhancement image. We give patients gadolinium contrast. We wait for 10 minutes and we take a picture. And the gadolinium has now accumulated in abnormal areas of myocardium. So essentially areas of the myocardium where the cells have died and there is extra space. Okay, so the cells have died in this little white stripe down the center of the septum. Okay, so this is midwall myocardial fibrosis. Okay, so this is where the healthy muscle, which is the black bit either side, and then the scar down the middle. And this is because the cells have died in the center of the septum, and the gadolinium is accumulating. And where gadolinium is accumulated, we get bright white scar. Okay, so midwall myocardial fibrosis we see in about 30 to 50% of dilated cardiomyopathy. And we'll talk a little bit about the significance of that on the next slide. And then this image is not a picture of someone with dilated cardiomyopathy, but a picture of someone who's had a myocardial infarction. Okay, so someone presents with a weak ventricle. Is it caused by a non-ischemic process? Dilated cardiomyopathy is a non-ischemic process. It's an intrinsic problem with the muscle rather than an acquired problem. Okay, and here we see that the scar is not in the middle of the wall, but on the inside of the wall. Okay, so the coronary arteries perfuse the myocardium from outside to in. Okay, so the coronary arteries are on the epicardial surface of the heart, so the outside of the heart. So whenever there's not enough blood supply, the first bit of the muscle that becomes ischemic, becomes starved of oxygen, is the inside of the heart, the bit furthest away from the coronary arteries. Okay, so myocardial infarction, the muscle dies from the inside of the heart and we get what we call subendocardial infarction. Okay, so subendocardial scar or transmural scar is 95% of the time indicative of myocardial infarction. So tissue characterization of the ventricle using gadolinium as a contrast allows us to distinguish between ischemic processes on the right and non-ischemic processes on the left. So what other things can we do? We can look at a particular magnetic property of the tissue called the T1 time, okay? And we can measure the T1 time of each pixel of the heart. And then we can make a nice picture with the color of each pixel corresponding to the T1 time in that image, okay? So you can see the T1 time here in the myocardium, where it is all green, is all nice and normal, okay? And the things that make our T1 times go up or down are things like interstitial fibrosis, so collagen forming in between the cells rather than the cells dying, okay? Or if we get deposition of protein like amyloid, okay, or storage of glycogen or other abnormal substances inside our cells. Okay, so T1 mapping can be helpful, but it's generally not particularly helpful in dilated cardiomyopathy. You can also use T2 weighted image, and T2 weighted imaging essentially allows us to pick up water in the heart. Okay, so whenever water's in the heart, then our T2 time increases and things appear white or bright on T2 weighted imaging. So here on the left, we see a little bright area down in the inferior wall here where there's fluid in the heart. And here we see a T2 map, which again measures T2 time inside the myocardium and assigns a color to the pixel depending on the T2 time. And water inside the heart essentially means inflammation. So this allows us to pick up inflammation. And T2 weighted imaging can be helpful in people who have acute heart failure and acute presentation of dilated cardiomyopathy, as it can help us diagnose myocarditis. Okay, so this can be occasionally useful in patients who present with acute presentations. Okay, so T2 weighted imaging, you'll either see it called stir imaging, which is this image on the left, or a T2 map, which is this image on the right. And anything with increased T2 time or increased T2 signal is indicating that there is inflammation or edema of the muscle. We can also do stress perfusion imaging, which is up on the right-hand side of the heart, or the right-hand side of the slide. And this looks at the blood supply at rest and on stress. And this looks for ischemia, essentially. Okay. I tend not to like to do stress perfusion imaging in people with very severe dilated cardiomyopathy. We want to stress the heart with usually adenosine, okay, and we want to pick up mismatch in the blood supply between rest and stress to indicate ischemia. And it can be difficult to stress the heart with adenosine confidently in someone with very poor heart muscle function. So I tend not to do stress perfusion imaging in people with very severe dilated cardiomyopathy, and I'd rather do an anatomical test of their coronary arteries, like a CT coronary angiogram. So why do we do MRI and dilated cardiomyopathy? Well, we do it to confirm the cause of someone's heart failure. So when someone presents with dilated cardiomyopathy, they generally or most frequently present with heart failure. And the question is this a non-ischemic intrinsic problem with the heart muscle, so dilated cardiomyopathy, or could it be caused by coronary artery disease, ischemic heart disease? Okay, and this study from over 20 years ago looked at a couple of hundred patients who had presumed dilated cardiomyopathy after having an angiogram whenever they first presented with the heart failure. And they actually found that 13% of people who had presumed non-ischemic cause of their heart failure actually had an infarct here on the right. Okay, so this is what we call a transmural infarct of the septum. So this is near transmural myocardial enhancement of the septal wall going into the anterior septum. Okay, transmural just means that it's gone through the whole wall. Okay, and essentially this muscle is dead and not going to wake up. Okay, so a proportion of people who we think of non-ischemic heart failure actually will have heart failure caused by a previous myocardial infarction that's been unrecognized. Okay, so that's the first reason we do CMR and dilated cardiomyopathy. It also then lets us help risk stratify patients. So it helps us determine their risk of sudden death. Okay. And this is all related to this mid-wall myocardial fibrosis that we pick up maybe in a third to a half of patients. So it's this white stripe down the center of either the septum or the free wall of the left ventricle here. We also see some subepicardial enhancement, this white stripe here in the inferior and lateral wall. And this corresponds to areas of fibrosis whenever we look at the heart under a microscope. Okay, and fibrosis is the basis for creating re-entry circuits for ventricular tachycardia. Okay, so whenever the electrical impulse hits areas of scar, it becomes slow, and this allows us to create conduction block and then a little re-entry circuit. Okay, so whenever we look at patients with dilated cardiomyopathy, if you have this appearance on MRI, you're about 5 times higher risk of having sudden death or an aborted sudden death compared to those people without fibrosis. Okay, and this is now being confirmed in lots of other papers. Okay, so SCAR indicates a disproportionate high risk of sudden death compared to patients without SCAR. And actually, if you don't have SCAR, then your risk of sudden death is very, very low. So it not only tells us those patients who we should be thinking about implanting an ICD in, but also tells us those patients who probably will be okay without an ICD. If you don't have SCAR, your risk of sudden death is very low. And there's now lots of randomized trials going on to try to prove that using MRI to select patients for an implantable defibrillator is a good thing. And hopefully these trials will show that it improves outcomes in our patients. You'll see lots of things written about possibly trying to quantify the amount of scar in someone's heart. And this is also relevant in hypertrophic cardiomyopathy. And here we essentially use different software to try to estimate the area that is white within the black muscle. Okay, and they'll do this in different ways using different approaches. Okay, and it can be good, but most of what we've found in research is done in a single center by very experienced people using very standardized things, very standardized techniques. And I think actually, if we try to translate this into every center around the world measuring scar, it'll become very irreproducible. Okay. And we'll get lots of variation between different people and how we measure it and lots of different answers. And I think we will then lose the potential benefit of quantifying scar. And I think it can be difficult in dilated cardiomyopathy, particularly because the walls in dilated cardiomyopathy are very thin and it therefore becomes more precise. So I currently don't think that this is going to be particularly helpful unless we can develop validated automated ways of doing it using AI or something. And then the final reason we should or do MRI and dilated cardiomyopathy is to try to pick up specific genetic forms of the disease. Okay, so we know that particular genetic forms of the disease are associated with characteristic patterns of scar. So this is a paper from a few years ago that showed that patients with truncating variants in desmoplakin or filamin C often have this ring-like pattern of fibrosis involving lots of segments of the heart, often in the subepicardium of the lateral wall, so originating from the outside of the heart. Okay, so this gives us an idea, a pointer towards these types of genetic disease and when we should be particularly thinking about doing genetic testing and also screening families perhaps a bit more expediently. So this was a case from one of my clinics a few years ago, a 39-year-old chap who presented just with mild reduction in his exercise tolerance. He'd had some palpitation and he'd had a Holter monitor done privately that showed some non-sustained ventricular tachycardia. And his initial MRI scan just showed mild LV impairment, but it showed quite extensive mid-wall and subepicardial myocardial fibrosis. So again, down the center of the heart and then all the way up his lateral wall here. Okay, so a nasty type of fibrosis that we would think, that links in nicely with genetic phenotypes of the disease. And his family history was, as it often is, had uncertainty in it, but within that uncertainty, it certainly raised some alarm bells. So his father had had an out-of-hospital cardiac arrest that had been attributed to a heart attack, hadn't had a post-mortem, and there was certainly a question mark over the cause of it. And then his brother had died from heart failure at the age of 48. And actually, interestingly, we first did his genetic panel in 2018 and it came back as normal, and we repeated it again in 2020 when filament C was added to the panel because his phenotype was so in keeping with it, and indeed found a nonsense variant in it. And again, these are some studies that look at filament C and the risk associated with filament C in terms of heart failure and sudden death. So the red and green lines essentially show that the increased risk of heart failure events increases as your ejection fraction drops. So we have ejection fraction along the horizontal axis. As your ejection fraction drops, your risk of heart failure events increases. And this flat line here is your risk of sudden death, which essentially shows no matter what your ejection fraction is, whether it's 50% or 20%, your risk of sudden death is the same, and it is increased. So we should forget about ejection fraction with filament C whenever we're thinking about ICDs, and we should have a lower threshold to implant them. Okay. What else can we look for? Well, we can also look for fatty infiltration. And this is a bit more difficult to pick up, but here we see someone with an ICD. And in the lateral wall of the heart, we see that it looks like someone's taken a little bite out of the heart here. Okay. And in the right-hand side of the image, we see a very irregular appearance to the lateral wall of the heart. And we see something called chemical shift artifact, which is what happens whenever fat is in the myocardium on an MRI scan. Okay. We can also do other forms of imaging to confirm areas of fat in the heart. And here we see a little area of white fat inside the black muscle. Okay, and picking up fatty infiltration in the heart is important because it's a key hallmark of arrhythmogenic cardiomyopathy or desmosomal type of diseases. Okay, so diseases caused by plakophilin or desmoplakin. Okay, and here we see someone with desmoplakin with lots and lots of scar in the lateral wall of their heart, but also some fat, so fibrofatty infiltration. Okay. So what other things do we look out for in arrhythmogenic cardiomyopathy? So again, this is a woman who presented with an episode of myocarditis on the background of arrhythmogenic cardiomyopathy. And in the left ventricle, we see areas of, in the right ventricle, we see areas of the right ventricle that don't move so well. So there's a little aneurysm here. This area of the right ventricle again has a little outpouching whenever it contracts, so it goes the wrong way essentially. Okay, and we also see a little bit of fat here. This is something called an RV in and out view. So this is the tricuspid valve. This is a pulmonary valve. And here we see that whenever the rest of the ventricle contracts, this place in the right ventricular outflow tract has a little bulge out. It is what we call dyskinetic. It goes the wrong way. Okay, and these are classical regional wall motion abnormalities that you'll see referred to as diagnostic criteria for arrhythmogenic cardiomyopathy. And they can be difficult to see on echo because our ability to look at the right ventricle is reduced. Okay, and with MRI you see it beautifully, and we can be more certain about the significance of it. There's also late enhancements. So this patient, although their cine imaging suggested that the predominant involvement was of the right ventricle, we can see that they have some scar in their left ventricle. So again, confirming that this is usually a biventricular disease rather than an isolated right ventricular disease. Because she presented with chest pain and signs of myocarditis, we also did a T2 map, and we see that there's a little stripe of orange within the pink here, okay, which is a sign of increased T2 times because there's water accumulating inside the myocardium and there's inflammation, okay. So these are all the different things that we look for in arrhythmogenic cardiomyopathy as hallmarks of the disease. We can try to pick up fat. I think we're having a lower threshold to look for evidence of inflammation because we know inflammation is often a presentation in patients with arrhythmogenic cardiomyopathy, and we can get nice pictures of both the left and the right ventricle. So this is just again a slide that confirms the biventricular nature of the disease. So again, an autopsy study done from the St. George's group that showed that 70% of patients with arrhythmogenic cardiomyopathy actually have disease in both ventricles. Okay, and actually isolated left ventricular disease seemed to be more common than isolated right ventricular disease. And there is a genotype correlation associated with this. So PKP2, plakophilin, usually presents with a right ventricular dominant disease, whilst desmoplakin usually presents with a left ventricular dominant disease. So what about hypertrophic cardiomyopathy? So perhaps the one that we see the most of, okay. Again, we do cine imaging to get beautiful images of the pattern and the extent of hypertrophy. Some patients will have quite focal patterns of hypertrophy. This patient has relatively focal hypertrophy of the basal anterior and anteroseptal walls. Okay, so if you imagine an echocardiogram cutting across like this and like this and like this, it's very possible that they will miss very focal hypertrophy, or at least the point of greatest hypertrophy. Okay, so MRI gives us again characterization of the ventricle without the anatomical barriers of echocardiography. Okay, we can do late gadolinium enhancement imaging. So again, we see scar areas of white within the ventricle. We often see scar forming at the insertion points. The insertion points are when the right ventricle inserts into the left ventricle, both at the anterior aspect of the heart here and the inferior aspect of the heart. So here we see a big lump of white scar at the anterior insertion point where the greatest hypertrophy is. Okay. We can look for edema with T2 imaging. And again, sometimes we do see areas of myocardial injury or edema in patients with hypertrophic cardiomyopathy. T1 mapping is occasionally helpful in patients presenting with hypertrophic phenotypes of the disease. And that's because some hypertrophic phenotypes will be caused by amyloid, okay? Amyloid gives us very, very high T1 and extracellular volume values, so ECV and T1 values, okay? And that can help us make the diagnosis of cardiac amyloidosis, particularly early cardiac amyloidosis, whenever we don't have other cardinal features of the disease. And the things that give us very low T1 values are things that accumulate either glycogen or sphingolipids or other things within inside our cells. Okay, so storage disorders like Fabry, Prague-G1, Danon disease, and some mitochondrial disorders will give us low T1 values. So high T1 values, very high T1 values, think amyloid. Low T1 values, then think storage disorders or mitochondrial disorders. In hypertrophic cardiomyopathy, perfusion abnormalities are almost ubiquitous. Okay, so this is a stress perfusion map in the top right. Okay, this shows perfusion of the heart. The orange bits are normally perfused, the purple bits are abnormally perfused, and the dark purple bits are very abnormally perfused. Okay, and here we see abnormal perfusion in the areas of greatest hypertrophy. Okay, and this is almost certainly driven by microvascular dysfunction associated with left ventricular hypertrophy. Okay, so we see this, almost ubiquitously in our patients. So if we know it's going to be there, what's the point of doing it? And at the moment, it doesn't really change how we manage people. Okay. If someone has symptoms of typical angina with hypertrophic cardiomyopathy, you might want to rule out significant coronary artery disease with a CT coronary angiogram. But if they don't have significant coronary artery disease, it's safe to assume that it's probably due to microvascular dysfunction and we should just treat it. So again, I don't do this ordinarily in patients with hypertrophic cardiomyopathy unless there's a very good reason. But other people do like to do it because they like getting information. So again, how do we diagnose hypertrophic cardiomyopathy? Again, it's all based on wall thickness above 15 millimeters in the absence of hypertension or aortic stenosis. We can go down to 13 millimeters if there's a first degree relative with confirmed disease. Okay. But so measurement is key in making the diagnosis, but again is very poorly reproducible. So this image on the right shows a short axis image, and it shows 3 different plausible measurements that a cardiologist could make that vary between 19.6 millimeters and 33.2 millimeters. Okay, so huge potential variation, and these kind of huge impacts on our decisions to give people ICDs. So can we become more reproducible? Again, this is a colleague from the Royal Free, Gabby Capter, which again showed huge variation between expert clinicians measuring maximum left ventricular wall thickness across echo and cardiac MRI. Okay, and another paper from people at Barts showing that machine learning and AI algorithms are a lot better than expert clinicians at measuring wall thickness. Okay, so I think we will see AI take over our jobs of measuring wall thickness, and they will probably do this a lot more reproducibly than we will. So what about the heterogeneity of hypertrophic cardiomyopathy? We know that there's lots of different patterns of hypertrophy that can present as hypertrophic cardiomyopathy. So these are all examples of patients with hypertrophic cardiomyopathy recruited to a large international registry of hypertrophic cardiomyopathy. In A, we see someone just with isolated hypertrophy at the base of the septum. Okay, in B, we see what we call a reverse septal curvature pattern. Okay, so it has this nice, almost kind of semicircular appearance. Okay, C is a typical case of apical hypertrophic cardiomyopathy where the thickening's all at the apex. Okay, D again is a pattern of reverse septal curvature like B. Okay, E is a pattern of mid-ventricular hypertrophy with a large apical aneurysm, and F is a slightly unusual pattern of hypertrophy that's isolated almost to the lateral wall. Okay, so we can see all of these different patterns of hypertrophy, and why is it important? Well, because there's a variability in how likely they are to be a sarcomeric form of hypertrophic cardiomyopathy, or how likely we are to find a genetic variant. Okay, so those patients with this reverse septal curvature pattern of hypertrophy were a lot more likely to find a variant in MYBPC3 or MYH7 compared to all of these other forms of hypertrophy that we see more commonly in older populations, and perhaps those also associated with things like hypertension. So what about late enhancement and hypertrophic cardiomyopathy? We know it can help us identify those patients at high risk of sudden death with dilated cardiomyopathy. Oh, am I back? I think my connection dropped out there, but anyway, hopefully I'm still with you. Yeah.
You're still here. Still here.
So can it help us risk stratify patients with hypertrophic cardiomyopathy? And yes, the answer is it can. Again, we see different patterns of late enhancement or fibrosis and hypertrophic cardiomyopathy. We see enhancement mostly at the insertion points. So we see this very big dense lump of white enhancement at the insertion points here, and then slightly grayer enhancement in between. We tend to see it in the greatest areas of hypertrophy, which tends to be the septum. Okay. And if we see other patterns of enhancement, we should think about other causes of thick hearts beyond hypertrophic cardiomyopathy. Okay. Patients with sarcomeric variants in this HCMR registry tended to have more scar than patients without sarcomeric variants. So again, perhaps it can help us identify those patients most likely to have a positive genetic test. This was one registry looking at the percentage of late gadolinium enhancement and the risk of sudden death across patients with hypertrophic cardiomyopathy. So when we get above 10% and certainly above 20%, we begin to see risk increase. So for dilated cardiomyopathy, I wasn't particularly optimistic about measuring the extent of enhancement, but in hypertrophic cardiomyopathy, we almost need to measure the extent of enhancement because the vast majority of patients have some enhancement. So we need to try to grade the extent in order to use it as a way of differentiating risk amongst the population. And there's lots of papers that have now shown that the extent of late gadolinium enhancement provides incremental value on top of our traditional risk scores in trying to identify those patients who are at highest risk. And perhaps we should be thinking about using this as an arbiter of who gets an ICD whenever patients fall within the grey zone and we're not sure what to do. So this has become a recommendation in both the American and the European guidelines, but it is generally as a bit of an arbiter whenever our approach to risk stratification is uncertain from all the other things that we do to try to prevent sudden death. So left ventricular outflow tract obstruction is another hot topic. And an MRI can help us delineate the cause of left ventricular outflow tract obstruction. I'm sure lots of us are using mavacamten to treat this, and many of you will be familiar with surgical techniques like septal myectomy or alcohol septal ablation. And it's important that we pick the right technique for the right patient. Okay, in the top left-hand corner, this one, we see a typical case of hypertrophic cardiomyopathy. We see the reverse septal curvature pattern of hypertrophy, mainly involving the septum. Okay, we see slightly elongated mitral valve leaflets here. Okay, and whenever the heart contracts in systole, we see that the anterior mitral valve leaflet gets sucked over and touches the septum. Okay, so this is systolic anterior motion of the mitral valve causing left ventricular outflow tract obstruction. And we see some flow acceleration because of artifact in the left ventricular outflow tract. And we see a big jet of mitral regurgitation flowing back into the left atrium because the coaptation of the anterior and posterior mitral valve leaflets has become abnormal. So this is typical left ventricular outflow tract obstruction caused by sarcomeric hypertrophic cardiomyopathy. The one in the top right is slightly different. There's not much hypertrophy in the septum. Okay, so this is not going to be a great candidate for septal myectomy. Okay, the cavity is small. The angle between the aorta here and the septum here is very steep. So if we compare the angle between this heart, between the aorta and the septum, and this one is almost at right angles. So this is what we call steep aortoseptal angulation. Okay, so this is not necessarily someone with hypertrophic cardiomyopathy, but this is someone with mild left ventricular hypertrophy, steep aortoseptal angulation, a little small left ventricle that's very dynamic, and that creates the systolic anterior motion of the mitral valve, and flow acceleration and outflow tract obstruction here. Okay, so this is not someone with hypertrophic cardiomyopathy, but someone who is probably old with a history of hypertension. This patient down the left is again another interesting patient. So they have probably mild to moderate septal hypertrophy, but their main abnormality is that one of the cords from this papillary muscle doesn't insert into the tip of the mitral valve leaflet, but inserts into the base of the mitral valve leaflet, just beside the aortic valve. Okay, so this is an anomalous cord that inserts into the wrong bit of the mitral valve apparatus. Okay, and this anomalous cord gets sucked over into the left ventricular outflow tract and causes left ventricular outflow tract obstruction. Okay, so almost certainly when this patient becomes symptomatic, and interestingly, he's not symptomatic at the moment, he will need a surgical repair of this. Okay, and probably a replacement of his mitral valve. Okay. And then this final patient, again, is a recent patient in clinic, a woman in her 60s, and she has an abnormal mitral valve. So her anterior mitral valve leaflet is very thickened. It has a hockey stick appearance or some mitral stenosis, but she also has a little ridge, okay, a fibromuscular ridge coming off the bottom of her septum. Okay, and that causes left ventricular outflow tract obstruction rather than typical systolic anterior motion of the mitral valve. So this woman has a subaortic membrane or a subaortic ridge that needs to be resected by a surgeon to improve her left ventricular outflow tract obstruction. So MRI can give us all these pretty pictures that gives us good information about how to treat the left ventricular outflow tract obstruction most successfully. Okay, it also gives us lovely images of apical aneurysms. So apical aneurysms can be difficult to detect on an echocardiogram because the echocardiogram takes pictures very close to the apical aneurysm, and the beam sometimes struggles to pick up things too close to it. Okay, so MRI is very good at doing that because it doesn't have these anatomical restrictions. These are two patients with apical aneurysms, the one on the top, a little tiny apical aneurysm, and the one on the bottom, a bigger apical aneurysm. And this little black thing that sits within the aneurysm is a little clot. Okay, so it allows us to pick up apical aneurysms and look for clots. And if we go to the American and the European guidelines, there's a discrepancy about how we deal with these. So the Americans say that all patients with apical aneurysms should have an ICD, and the European ones say that we shouldn't use apical aneurysms as an assessment tool. We should just use the ESC risk score. So again, this is a slightly controversial area at the moment. So I talked a little bit about phenocopies. So phenocopies are things that can mimic hypertrophic cardiomyopathy. Okay, and I'm sure lots of us have these patients sitting in our clinics, and we haven't spotted that they're not typical hypertrophic cardiomyopathy. So we need to try to spot the zebras amongst the horses. Okay, and MRI I think is extremely helpful in identifying this. So this was a young chap who's in my clinic who's in his 30s. Okay, and he presented with syncope, then DNA'd, and came back a couple of years later with heart failure. Okay, and the MRI here shows that the pattern of hypertrophy is quite concentric, so it's not asymmetrical. It involves all walls of the heart to an equal extent. Okay, and rather than a heart that squeezes too much or has very dynamic squeezing function, the function of his heart is reduced. Okay, so his ejection fraction is probably in the 40s here. Okay, and the pattern of scar here that we see in the middle bottom image is atypical for hypertrophic cardiomyopathy. So it almost spares the septum, okay, and the anterior insertion point, and involves the lateral wall in a kind of very diffuse way with extra little punctate lesions. Okay, and this was his T1 map. And again, in the areas where there's fibrosis on the late gadolinium enhancement image, we see probably normal T1 values. And in the septum, we saw that the T1 values were lower than normal. Okay, so after lots of investigation and sending him to for a biopsy of his ventricle, we diagnosed him with a mitochondrial condition. And this is now, I think, being put on some HCM panels, as it's now being recognized as a relatively frequent mimic of hypertrophic cardiomyopathy, and one that can present with isolated cardiac phenotypes. So I think the Oxford team have put this on their HCM panel, and I think others will follow suit. So I think it's important for us to be aware of these things and ask questions whenever we see things that don't appear typical of hypertrophic cardiomyopathy. This is another case, a case of a child. So I think she was 12 when she first presented following a sudden death in her mother. Okay, and these are two scans less than a year apart. Okay, and in that year, we see very rapid progression of hypertrophy. So here, the wall thickness of her septum looks normal, and 11 months later, it's progressed hugely. Okay, and here we see fibrosis images, and again, very little fibrosis in her heart in the top image, and in the bottom image, she's started to develop some fibrosis here, and then also here. Okay, so whenever we see very rapid progression of hypertrophy or significant hypertrophy in young people, again, we should think of other causes. And this patient had a LAMP2 variant on genetic testing, was diagnosed with Danon disease, which explained her mother's sudden death at a young age. And sadly, actually, this young woman went on to develop a rapidly progressive phenotype and develop advanced heart failure, and sadly died when she was 18. So there are now gene therapy trials for Danon disease. Okay, we need to pick up these phenotypes early to give patients treatment before they develop advanced heart failure, and give them a chance of improved outcomes. So things that I look out for hypertrophic phenocopies, things that aren't hypertrophic cardiomyopathy. If there's extreme or rapidly progressive hypertrophy, is if the fibrosis or late enhancement is in atypical patterns, if they have low T1 values, or if they have extra cardiac features on examination. Lots of them will present with pre-excitation, so short PR intervals on an ECG like this one. Another woman with a mitochondrial cardiomyopathy in the bottom right, who again has a very unusual pattern of hypertrophy and also fibrosis. And if we're thinking about these types of things, then we should start with an HCM panel, but then perhaps progress on to other things in more specialist investigations, and involve our colleagues in metabolic medicine, and also the mitochondrial teams. I'll talk a little bit about sarcoid, because I think sarcoid's important and MRI is good at diagnosing it. So sarcoid's a granulomatous condition that can present with DCM, it can present with HCM, it can present as arrhythmogenic cardiomyopathy. I have a chap in my clinic who I saw recently who had a diagnosis of arrhythmogenic cardiomyopathy made 10 years ago. He's gene negative. His daughter's been under follow-up. We repeated his MRI scan. His MRI scan was more characteristic of sarcoid. We've now done an FDG PET scan, and I think we will make a diagnosis of sarcoid in him, and that has huge implications then, of course, for his daughter as well. So sarcoid can present in any way. It can present with late enhancement patterns in any territory, often across multiple different territories, in multiple different patterns, and in multiple different locations. So the left-hand side image is fairly typical. We see some subepicardial enhancement here. We see enhancement of the right ventricular side of the septum here and here. And then we see some endocardial enhancement here. And there's probably also some enhancement of the right ventricle down here. It can also present like infarct, so it can also present with subendocardial enhancement. Okay, so late enhancement's important at picking up patterns that may be sarcoid-like. It can identify active disease using T2 mapping. So this stir image with this bright area of myocardium here showing increased stir signal, evidence of inflammation in the heart. Okay, these patients should have a PET scan to confirm the inflammation and then go on to immunosuppression. So late enhancement and T2 weighted imaging are the most important things in sarcoid. We can also pick up evidence of extracardiac disease. So this is the heart in the center. We see the pulmonary arteries and we see lymph nodes around the pulmonary arteries. Okay, so this is mediastinal lymphadenopathy, which is almost certainly extracardiac sarcoid. Okay, so if someone has an extracardiac diagnosis of sarcoid, the chances of their cardiac findings be due to sarcoid is vastly increased than if someone doesn't have any evidence of extracardiac sarcoid. So context is key, and pretest probability is key whenever we're trying to interpret these images. Okay, and the pattern of enhancement in sarcoid can be very variable. So all of these cases are patients with sarcoid. Okay, here we see enhancement of the right ventricle and going into the left ventricle. Here we see someone with ring-like pattern of enhancement of their left ventricle. Okay, and this matches areas of increased stir signal here and here, showing that there's evidence of inflammation. Okay. And again, someone with lots of mediastinal lymphadenopathy and lung disease to suggest that they have extra cardiac evidence of the disease. I'll finish off just talking quickly about amyloid. So amyloid is a diagnosis that we're making more commonly. And the reason we're making it more commonly is now that we have disease-modifying treatments for people with transthyretin amyloidosis, as well as light chain amyloidosis. So TTR amyloidosis is whenever someone produces an abnormal form of the TTR protein. That might be genetic, or that might be because of people are getting older, what we used to call senile amyloidosis, now we call wild type amyloidosis. Okay, and when you produce abnormal TTR protein, instead of being a tetramer with 4 bits to it, it dissociates into monomers, and those monomers get deposited in the heart or the nerves. Okay, when they get deposited in the heart, we get hearts that can be mild to moderately thick, but the predominant problem with them is that they become stiff. Okay, so in the top left here we see a stiff ventricle. Okay, in the bottom left we see a very atypical late gadolinium enhancement image. So we see that the blood pool here is black. Okay, which is very abnormal. It's unlike any other late gadolinium enhancement image we'll see. Okay, and then the endocardium, the inside of the heart, is white. Okay, so there's diffuse subendocardial enhancement, and that's because there is amyloid protein deposited inside the heart, and there's lots of scar and extracellular space for the gadolinium to accumulate. We get very high T1 values because the amyloid protein pushes that up. We get very high extracellular values, extracellular volume values, because the cells die. There's lots of protein and scar deposited in the extracellular space. Okay. We also get evidence of myocardial injury and edema, and the T2 values go up. So whenever we have an MRI that's typical of amyloidosis, it can be pathogenomic. It can be diagnostic of the disease. Okay, these patients are often very sick. So in the top left here, we see someone with huge pleural effusions. So the black bits here are the lungs, and the fluid around the lungs appears bright. Okay, and here we see very typical T1 maps where we see very elevated T1 signal because of the deposition of the protein in the muscle. And these are typical late gadolinium enhanced images where the blood pool is darker than the white myocardium, which has lots of amyloid inside it. This is another image called an early gadolinium enhanced image, and here we pick up a little dark area inside the pulmonary artery, and this is a pulmonary embolus inside the pulmonary artery. These patients are often very sick, and we often pick up these coincidental type of findings and make other important diagnoses. So as I said, it's important to make these diagnoses because we now have dedicated treatments for TTR amyloidosis. Okay, TTR is when we produce abnormal protein in the liver. Instead of it forming tetramers, it dissociates into monomers, which then get deposited inside the heart as amyloid fibrils. We can silence the TTR gene to stop producing the protein. We can stabilize the TTR protein in tetramers and stop it dissociating into monomers. So this is tafamidis, a TTR stabilizer, or patisiran, a TTR gene silencer. And we may also have the ability to get rid of the amyloid deposits whenever they are inside the heart by using specific monoclonal antibodies. And of course, these new agents have dramatic improvement on people's life expectancy, particularly when we use them earlier in the disease and stop patients from getting advanced heart failure. So that's the end of my talk. I'm happy to take any quick questions, and I hope some of you learned some new things about MRI.
There's just one question in the chat there, Brian,
Sure.
from Manish.
So yes, good question, Manish. So my personal take and the way we do it at the Royal Brompton is that we don't report quantities of late gadolinium enhancement on MRI for hypertrophic cardiomyopathy. But I will comment whether the extent of late enhancement is extensive or more than I would expect. Okay, so I make a qualitative assessment rather than a quantitative assessment. And again, having, as part of my PhD, I quantified late gadolinium enhancement on about 1,000 patients with dilated cardiomyopathy. And I just don't believe that it is reproducible enough for us to be using ordinarily in clinical practice. So currently I don't use it, but I will report a qualitative extent of hypertrophic cardiomyopathy, whether it is extensive or not. But it's a controversial thing, and I'm sure you'll find other people that disagree with it. I think it's important for referrers to understand the drawbacks of it, and that it is not it is not as good as maybe everyone thinks. And I'm not sure that's the case for us to be using it widespread either at the moment. Super. So good question. The only thing I'm aware of about risk of location and prognosis is one paper suggesting that if there is subendocardial enhancement, then that is a sign of increased risk. I don't think, or at least I'm not aware of any evidence to suggest that septal wall enhancement is higher risk than free wall enhancement in hypertrophic cardiomyopathy. In dilated cardiomyopathy, we've published some work to suggest that multiple patterns of enhancement in multiple different locations in dilated cardiomyopathy is the highest risk. But I'm not sure about location in hypertrophic cardiomyopathy beyond subendocardial enhancement possibly being higher risk. I think location of enhancement in hypertrophic cardiomyopathy can point us towards phenocopies, but maybe not necessarily someone's risk of sudden death. Super.
Amazing. Thanks so much for your time, Brian. It's really, really interesting. So unless there's no more questions, we will just give you a quick poll for the final 2 minutes. So it won't take long at all. But yeah, thank you so much for your time this afternoon.
Sorry, that's me for the polls. So let me quickly just share my screen again. If everyone could go back to the mentee polls and we can quickly go through this. I'll give it a few minutes for everyone to join. Okay. So that's enough time. So the first one, do you feel more familiar of the use of MRIs in ICCs? So you can choose no, somewhat, or very. Okay. I think that's most people who have voted. And then the next question is, has your confidence in understanding MRI images or reports in the context of in ICCs improved? You can choose no, somewhat, and yes, quite a bit. Okay. Okay, and I think that's most people who have answered. And then the last one is, how would you rate today's talk? So you can show it on the sliding scale. Well done, Brian. Oh, amazing. I think that's everyone that's voted. So thank you so much, Brian. You've got a rating of 4.8. So thank you so much.
That's great. Thanks so much for everyone's time today and attending the session. Has been recorded and will be shared, and as of the other two series in this webinar. So that's sort of now complete. We've had the 3 sessions, but if you'd like to send those on to anyone they'd be useful, then please do. But thank you all for joining us today, and to Brian again for leading that session. So thank you, and see you soon for our next event, hopefully.